Bismillahirrahmanirrahim. So today let's talk about tachyarrhythmias. So I have talked about arrhythmias in the last video. So let's talk about tachyarrhythmias, right? So in tachyarrhythmias, I'm gonna discuss about various type of arrhythmias. Let's talk about sinus tachycardia. What is that, right? What happens in sinus tachycardia, right? We will see the high rate in more than if rate is more than 100 beats per minute, right? We're gonna call it as tachycardia, and if it was less than 60 beats per minute, we're gonna call it as bradycardia. So in approach to tachycardias, the next thing we need to check is to check the size of QRS complex, right? So QRS complex, whether it is narrow or broad, right? Narrow or broad. So there are two differences for broad complex tachycardia. One is ventricular tachycardia, another one is ventricular fibrillation, right? So when QRS complex is narrow, the next thing is to check the whether P wave is present or not, right? So P wave is present, and here P wave is absent, right? So when P wave is present, we need to check the Pu to QRS complex ratio, right? So if this ratio is 1:1, so we're going to call it as sinus tachycardia, right? And if we see the ratio is 2:1, 3:1, 3p, we'll see 3p waves, and after that we'll see this QRS complex. So these are flutter type of waves, so we're going to call it as atrial flutter, right? So if P wave is absent, so we will have to check the rhythm, right? So if there is rhythm is regular, we're going to call it a supraventricular tachycardia, and if rhythm is irregular, we will call it as atrial fibrillation, right? So that's how we're going to approach this patient on ECG, right? So let me erase this data from here. Okay, so so let's talk about the sinus tachycardia, right? So it is seen with mostly conditions like hyperthyroidism, right? It can be seen in fever, pregnancy, anemia, right, and heart failure. So this is a very important thing, that heart failure patients are going to have the sinus tachycardia, and they will be having low cardiac output, right? So, and also this is also seen with the beriberi, right? So treatment of these patients is beta blockers, right? Or we can also use calcium channel blockers. So the next arrhythmia, right? So let me revise that approach again. So we'll have to check the QRS complex size. If it is narrow, we'll have to check the P wave, right? If it is present, so it could be sinus tachycardia or atrial flutter. We'll have to check the ratio between P to QRS complex. The next thing is, if P wave is absent, we'll have to check the rhythm. If rhythm is regular, so we're going to call it as SVT, right? So we mostly call it as paroxysmal supraventricular tachycardia, right? Okay, so what happens normally, you can see here that this is SA node, right? So impulse is generated from SA node, and it flows to the internodal pathways, right? And then it moves both along the both sides of the AV node, right? And then it descends downward, and then it activates the bundle of waves and frequency fibers, right? But if there is some problem in AV node, that one side there is delay in impulse progression from one side. So what happens that there is some circus movement created, right? So again, this impulse takes over, this circuit takes over, and this again activates the ventricle again and again, right? So just don't follow the SA node. So because there is some re-entry phenomena, right, there is some circus movement that is created along the AV node, right? So we're gonna call, and because of the re-entry of the current, we're gonna call it a AV nodal re-entrant tachycardia, right? So we're gonna call it as AVNRT, right? So we'll have some types of AVNRT, and SVT is one of the subtype of that. Okay, so this patient is going to complain of recurrent palpitation, recurrent syncopal attacks, and dizziness, right? So let me define this first here. So it is an episodic narrow complex tachycardia at 140 to 220 beats per minute by rapid firing from AV node, right, or from abnormal focus that is present in atria, right? So we're going to call it as supraventricular tachycardia, right, because it is above the ventricle. This circus is present, this circus and re-entry phenomena, this is present above the ventricle, so that's why we're going to call it as proventricular tachycardia, right? So what happens in paroxysmal supraventricular tachycardia, patient might have some episode of palpitation, dizziness and recurrent syncopal attacks, but at the time of presentation ECG can be normal, right? So we can put these patients on Holter device, right? So Holter device is going to monitor 24 to 48 hours. It is attached to the body, right? So it's going to monitor, and then we'll have to check the data that is present in the microcomputer in this device, right? So it will show up some SVT, supraventricular tachycardia episodes, right? So causes are, sometimes it happens with that of anxiety, hypothyroidism, right? Caffeine intake, alcohol and tobacco intake, right? And infections in children can lead to SVT in supraventricular tachycardia in kids, right? So first we need to do is to resuscitate this patient, right? The very first thing we can go for is to check to activate the vagus nerve, right? So when we activate the vagus nerve, vagus is gonna hit the brakes on AV node, so that's how this is gonna delay the impulse that is coming from that is present. This is basically gonna delay the circus movement around the AV node, right? So first we need to do is to do carotid massage in these patients, right? And we can also go for Valsalva maneuver. Basically we are trying to activate the vagus nerve. So afferent nerve is Herring nerve, right? That is also known as the carotid sinus nerve, right? So it is basically a branch of ninth cranial nerve, and the efferent is vagus, right? So vagus nerve that is gonna supply the AV node and SA node, right? So when we don't need to do the massage continuously. We will have to do this massage intermittently, and this should be unilateral mostly, right? So before doing massage we will have to auscultate the carotids, right? Because when there is atherosclerosis, so if you do the massage, so there can be atheroembolic phenomena, and this patient can end up with a stroke, right? So when we auscultate the bruit, if it is present there, so this massage will be contraindicated. Also we cannot do massage in peds because of the short neck, right? So we'll have to use the face ice pack for vagal stimulation, right? So if it fails, we'll have to do unilateral massage, right? If it fails, so the second line is, we can do first line drug that is called as injection adenosine. We can give this patient. This is gonna turn off the circus movement around the AV node, right? So we'll have to give 6 mg IV stat, since its half-life is very small, right? Its half-life is a few seconds, almost 8 to 10 seconds. So we'll have to give this separately, and along with that we'll have to give the normal saline push, 10 to 20 cc normal saline push. So when it fails, basically we're going to attach this patient to cardiac monitor and we'll give this injection promptly, right? So if it fails, so we can give the injection we have to repeat this injection, and dose is increased here, that is 12 mg. If it fails again, we will have to repeat 12 mg again, right? And the alternate option that is we can use for these patients is injection isopten, right? So verapamil is basically it comes with dose of 2.5 to 5 mg, right? So we mostly give 5 mg dose injection isopten, 5 mg IV stat, right? So basically, so let me just repeat this again here. So if patient present with acute episode and systolic blood pressure is better, more than 90, so first we'll have to do the carotid massage, and then we'll have to give the injection adenosine, right? So if both of these fails, so the next step is to go for synchronized DC cardioversion, and we'll have to give the shock 120 to 200 joules, right? So this will be synchronized DC shock, right? If patient come in crashing form, like blood pressure is dropped, right, and patient is unstable, so we'll straight away go for this shock. that is 120 to 200 joules, right? So to prevent this, we'll have to ablate this circuit that is present, right? So that is present around the AV node, right? So we'll have to ablate this circuits, right? So right, we will have to go for EPS studies, right? And then we'll ablate these circuits. So to prevent the further episodes, we can give these patients Kelanes or tablet, that basically contains Europamil. So we can give these patients, right? So okay, so here we have this same approach here. That is, if patient is having heart failure or systolic blood pressure is less than 90, a patient is having altered state of consciousness and rate is more than 200 beats per minute, right? So if patient is unstable, we will straight away go for the DC shock, that is 120 to 200 joules per minute. If the patient is stable, so we can give these patients digoxin, amiodarone. These are the second line agents, right? So that's all about the approach to these tachyarrhythmias. So I'm going to discuss about ventricular tachycardia and ventricular fibrillation in subsequent videos. So that's all for today. That's all about sinus tachycardia and supraventricular tachycardia.